Hey everyone, this is Joe Minardi. Welcome back to the WVU Emergency Medicine Recording Studios. I am here to go through a quick little case-based point-of-care ultrasound topic with you all today. This case is about a patient with sore throat. So let's get right into the content here. This is a 19-year-old male who presented with sore throat. The patient had been seen a few days prior and to the pain of my soul, had a CT scan, was diagnosed with a peritonsillar abscess, was treated just with antibiotics, no attempt at any drainage or anything, and told to follow up in the ENT office and come back if things gotten any worse. Well, now it's a few days later and symptoms are getting worse. There's increased pain and swelling in the throat. So take a look in this patient's throat, and we see something that looks like this. Hopefully something you all recognize, asymmetric peritonsillar swelling. The uvula is deviated over here. I'm not going to beat these findings to death. Hopefully this is something we're all familiar with. Now, most of the time when I see these patients, and depending on my work setting, I like to diagnose these using an intraoral ultrasound technique, using an endocavitary probe, and just essentially placing it directly on the area of swelling and taking a look at it, and then often even draining these either dynamically or statically. But in some places that I work, I may not have ready or easy access to an intraoral probe, and so there are alternatives that we're going to talk about. Now, I'll take a little side tangent and say, almost any hospital where you work, there's probably an endocavitary probe somewhere. You just need to know how to get it. But that's a story for another day. But this is what I usually like to do, and you maybe have even seen some of my videos on YouTube. This is one of my favorites. But if you don't have easy or ready access to an intraoral or endocavitary probe, we're going to go over this other technique, which one of my colleagues was able to give me some really nice pictures that they did in this case. I first read about this and saw a video about this put out by Drs. Hensley and Dr. Lateplo from Mass General, probably I think in 2014. They've got a great video on this on YouTube, so check that out. There's also some good content on Academic Life in Emergency Medicine, emdocs.net, and a few other resources. So here's some of the images from some of those, but we'll go through some of ours as well. So the technique for this, it's a submandibular approach, and you can use the linear or the curvilinear probe. It kind of probably depends on how big your patient is or how much trouble you're having. So essentially, we come from the side and we bring the probe up just submandibular, and you're going to be under and medial to the mandible. So you're fanning in towards their neck or even slightly towards their trachea to try to identify this thing a little bit, obviously on the side that hurts. Now, one thing to keep in mind here is that since the probe is directed in this fashion, superficial is oriented this way, the far field in our image is directed towards the top of their head, and the near field is here towards the mandible. So this is our image, and then we have to kind of reorient that when we're looking at it on the screen. But here in this case, I hope you see, here's our abscess cavity. So this is the pus pocket in here, and we've got that highlighted there a little bit. And here's what it's going to look like on your screen, the way it's oriented, the way you're looking at it. So superficial or inferior, and then this is deeper or more superior. But here you can see this is the abscess cavity here, and this is the tongue sitting here. So just to kind of orient yourself, it may seem not super intuitive at first, but really not too complex. So this is how we're oriented. This is what the image is going to look like on the screen. And then by using this technique, in this case, what was done was an ultrasound guided and triangulated. This has been called the telescopic approach, where the ultrasound is external. You get the patient's mouth open, and then you get your 18 gauge spinal needles, what we typically like to use, and get it into the abscess cavity, and you should be able to kind of watch it with the ultrasound from the outside, confirming you're in the right spot, and then suck all that pus out of there. Super satisfying. These are great procedures. Patients feel a lot better after you're done with this. And I'm on kind of a mission. I think this is, I really want to put a stop to this. Most cases of peritonsillar abscess can be diagnosed without CT scans. And these are young patients. We really want to try to minimize radiating their upper neck and torso if we can. And we really don't. Using point-of-care ultrasound, most of the time, I think CT scan can be avoided. So that's one of my little soapboxes about this. And several studies have been done about this. This is a nice little review that was done by our colleagues over at the Ultrasound Gel podcast. Definitely check them out if that's not someone you're subscribed to already. And they did a nice review that showed here using point-of-care ultrasound to evaluate and possibly drain peritonsillar abscess dramatically increased the rates of successful drainage, and then just decreased a whole bunch of other stuff that you don't need. Decreased the need for any consults, decreased CAT scans, decreased follow-up or repeat visits, and decreased ED length of stay. You just look at these numbers and this data, and I think these are pretty compelling reasons to use ultrasound to help you diagnose these and help you drain them. And just, one of my other soapboxes is owning procedures in the department, having more mastery of your patients and taking care of them, and having to kind of rely on other people less is something that I think helps fight some of this burnout we keep hearing a lot about. The more you master your own, kind of master your domain, as George Costanza might say, the less burnout you're going to have in your professional career. And that's backed by some science and maybe a little bit of my opinion. But all right, so yeah, just quick recap. So we're not talking about this technique as much here today, but you can diagnose this using intraoral ultrasound, using the endocavitary probe, but specifically today talking about the submandibular technique using the linear or even the curvilinear probe under the mandible to help you identify this pus pocket here. Now, when you drain it, you can do this statically. If you look and you identify the abscess and you want to try to, if you identify it, you want to take note of the exact placement of the probe, the directionality, the depth, and get yourself fairly confident in where that needle needs to go based on your ultrasound. And you can just kind of put the probe to the side and then drain this. So that would be a static technique, and that works pretty well in most scenarios. Although I've just felt better and had better, quicker, more satisfying success most of the time when I do this dynamically. So that's what I do most of the time. But you certainly can do this statically. Once you've localized the abscess, just take note of your best placement where you saw the most depth and volume of that abscess, take note of that area, anesthetize it, and then get your needle in there. And then just other tips. Again, this is not the point of what we're doing today, but other things to think about. I usually have the patients gargle some 4% lidocaine, and then I'll inject the area where I anticipate to place the needle on top of that, and I've had good success with that. There are papers talking about using nebulized lidocaine or atomizing it even. I've tried those things, and I've felt like I've just had better success with gargling, but give those a try and see what you think works best for you. And I don't do incision and drainage unless maybe they've failed aspiration. Aspiration has a pretty high success rate, and what I typically use is an 18 gauge spinal needle. I take the sheath that comes with in the spinal needle packaging, and I cut it to expose about 2 centimeters of spinal needle to give me a little bit of extra protection and avoid deeper needles going where I don't want them. Another nice little tip is having the patient just hold a Macintosh Blade. That helps push the tongue down and gives you lighting. If for some reason you don't want to do this and you're using a tongue blade, or you're doing something where you have both hands occupied, an ENT headlamp is also a useful thing. But this is a nice little trick to use the Macintosh Blade to give you tongue retraction, give space in the mouth, and some lighting. So just in summary, mainly talking about the submandibular approach to diagnosing and helping guide telescopic drainage of peritonsillar abscess. So stick the probe under the mandible. Remember, your up-down is a little disorienting, and then you can guide the needle in. Here we can see the needle getting into this abscess and draining it, and you can avoid CT scans in these people, make them feel a lot better, decrease resources, time, consults, follow-up, and things like that. So using point-of-care ultrasound to help you with peritonsillar abscess helps you improve your diagnostic accuracy. Speed helps you successfully drain them more often, more quickly, saves time, resources, gives you more mastery of what you're doing in the department so that you have more control over your environment. And I think little things like that add up and help stave off burnout. There's the intraoral technique. There's also the submandibular technique that we just discussed. And you can do this in a static or a dynamic fashion to drain it with some of the tips that we talked about. So with that, I'll leave you with this. I hope that was helpful for you all. Let me know what you think, and I'll see you soon.